Thank you, Dr. Mudar. Any questions from the floor?
Of incision you use, either cold knife or laser or whatever it is, the ureter to have good successful repair should do a very nice peristalsis to be conductive from the kidney down to the bladder. If there is any sort of extravasation, it will end up with some fixation at this point, hindering the active propulsive peristalsis, which will result at the end of the day maybe stasis and hindering the good drainage of the system. The success can be temporarily good, but with more follow-up, it gets down and down to 40%. So the ureter is the organ is not to be incised like the urethra. The urethra we don't need peristalsis. The urethra just we need a channel conductive for the urine because there is a pressure generation from the bladder down to outside. But the ureter has to make an action to make propulsive under low pressure on the upper half and high pressure in the lower half. So this policy of endoureterotomy should be avoided whatever the other techniques can help. Why we repair the ureters and wrap it with momentum? Because of to prevent the fibrosis. But when you cut till you see the fat, you allow the urine to come outside and then induce fibrosis. So this, although mechanically it could be patent, you can pass even ureteroscope, but functionally it is not. So this is just a comment. Thank you.
I agree with you, but maybe in most of these series we don't have a long time follow-up, and many patients underwent other dilatation and stent and metal stents and many things.
Okay, what about uretero-pelvic junction in case of ectopic kidneys or recurrent uretero-pelvic junction obstruction? Do you have experience in case of ectopic kidneys?
I don't have in my own experience, but of course it will be the same principle how to deal with it.
Okay, thank you.
Thank you, Dr. Singh. Question session open to the floor for both topics, retroperitoneal fibrosis and uretroplasty with buccal mucosa graft.
Sir.
I have it here. Thank you very much for this elegant presentation, and of course this wide scope of techniques that could repair a defect in the ureter. But I'm still very concerning about the leakage of the urine, the inflammatory reaction around the area of the repair. And if you go back far away in the history of urology, there was a Davis indicated ureterotomy. There is no techniques at that time except they cut for the ureter, put stent, and leave the ureter to heal us. Why not? There is no need for this grafting. I don't know the fate of the graft, it will survive or not, because the follow-up histopathology, ureteroscopy, or see what the fate of this one in the ureter, or it is just the wrapping of the omentum which should do the job, and the ureter edges itself will creep over. But I don't know, I have to have a further, because we have a lot of experimental work in a dog model and in the rabbit model, and we did a histopathology examination of these segments, and there is no any traces of this grafting in the area. It is complete healing, but this is just a scaffold of that. I don't know what it would be, but this is our observation in it. But I'm still very concerned about how to keep the peristalsis of the ureter that is a viable organ for good conductivity. And because the retroperitoneal fibrosis is a fibrosis outside the ureter, but it hindering the peristalsis. It is mechanically patent, but functionally is not. All this extensive surgery may result in the same iatrogenic retroperitoneal fibrosis in the ureter, but the secret of success is a very long-term follow-up, not only a few months, but we have to make sure that this will work for a longer time.
Thank you for your comments, sir, and I agree with each of your comments in letter and spirit. At my institution, there is when you are joking with each other, you always say ureterocalicostomy is stage 1 nephrectomy. So that is a possibility, but as you cannot see these kidneys dying, so you have to do something, and it is an endeavor to do that. And but I take one of your points very seriously, and I think I'm going to go back and scope these patients to see what happens inside. That will give us valuable information. Thank you for your comments, sir. Sir, please.
Yeah, thank you for this two very nice presentation. Actually, you presented a couple of videos. It's very demonstrating. And my question is regarding the last one about the use of the buccal mucosal graft in ureteric stricture. Actually, you know that the ureter doesn't work like as a conduit. The transmission of urine from the kidney to the bladder depends on the peristalsis. By using this buccal mucosal graft, there wouldn't be any peristalsis in this segment, especially you are lying in stricture part, and the buccal mucosal graft, which has no innervation, has no peristalsis. And as you know that there is what's called functional obstruction. So my concern is about the long-term follow-up of such cases. So this is the first observation. The second one, in your opinion and from your experience, what is the maximum length of the ureteric stricture that you can use the buccal mucosal graft in such cases?
So thank you for your question, and they are both very insightful questions, I must say. The first point is extremely well taken, that ureter is not a tube. It is not a conduit. It is a functional organ. So when you put in an interposition, say you put in an appendix or you do a Monty flap, what happens is they somehow still function, but there is residual hydronephrosis. In this particular procedure basically competes with something like a small segment Monty or an appendix on the right side. Here you are still preserving one wall for whatever worth it may be. So as compared to these two procedures, it may in that sense have a benefit because one wall is still continued. But the peristalses are never going to be normal. These patients are going to have some residual hydronephrosis. How do they fare after 5 years from here is a question that remains to be answered. Because my individual follow-up is also about 18 months or so, and we looked at Lee Zhao's data that was about 24 months. So we do not have long-term follow-up. And proof of the pudding is in eating, so we'll have to wait for that. Sir, as regards to your second question, what is the maximum length? I think, sir, more than 5 centimeters becomes difficult to handle.
Thank you very much, Dr. Singh, for the very nice presentations and talks and the demonstration of the technique. My question on the first talk, actually, about retroperitoneal fibrosis, which is sometimes it's a dilemma for all of us to treat, taking a biopsy and everything. So you mentioned that probably you take a biopsy in every patient. But
yes, 100%.
I came across an algorithm for treatment, and they mentioned something about doing a PET scan for every patient at the beginning, and if there's a hot spot, then you proceed for biopsy, because at that time either it's probably a very active inflammatory disease or versus cancer, and cancer is what we're actually worried about, as you indicated, and that's what ultimately makes us take the biopsy. However, if it's cold on the PET scan, then we don't have to really proceed with biopsy. What's your take on that?
So one thing is, firstly, regarding doing PET scan, I think doing a FDG PET for all retroperitoneal masses is a very good idea, because a disease which has a systemic uptake is an active disease. But the point is that this active disease can be both a retroperitoneal fibrosis-like disease, that is, it can be an IgG4 disease, as well as it can be malignancy. So, but it definitely tells you that there is an active disease. As regards to biopsy, why you should biopsy all the cases is that if the disease is in remission right now, that means you don't see FDG uptake. That doesn't mean that this patient does not require treatment. He still requires treatment. If there is a thick sheet of tissue which is encasing both the ureters, and it is a burnt out disease, that means it is not active on FDG PET, but still this patient requires treatment. You will have to give him steroids. You don't know when this will get activated.
Yeah, probably the distinction is if that patient has cancer or not. So you might have a good idea if you do a PET scan. And you go from there. So if it's cold in the PET scan, you probably can skip the biopsy part and go for medical treatment like steroids or anything else safely. But if it's hot on the PET scan, at that time you will have to insist probably on the biopsy, and biopsy is probably mandatory at that time. What do you think?
So active retroperitoneal fibrosis, which is not a malignancy, is also hot on PET scan. So that does not help you differentiate. What helps you differentiate is that if it is a sheet of tissue, it is more likely to be idiopathic retroperitoneal fibrosis or IgG4 disease. It's nodular, then it is likely to be malignancy. If there is uptake limited only to the pancreatic bed, the head neck face, and the biliary tree, it is likely to be retroperitoneal fibrosis. But there are nodes everywhere. There is uptake in the uterus, ovaries. This is less likely to be retroperitoneal fibrosis, more likely to be malignancy. So in that sense, it will make you wiser. But I would suggest that biopsy should be done in all the cases, because IgG4 disease has slightly different management than idiopathic retroperitoneal fibrosis. So for the gamete of only retroperitoneal fibrosis patients also you require a biopsy. And most of the times they can be done percutaneously. In our discussion, we were talking about what is a surgeon's role. Therefore, those two examples of, say I would have dealt with about 10 patients last year, and out of that 2 required laparoscopic biopsy. Just to bring about the role of surgeon, I demonstrated those cases. But you could do a percutaneous biopsy.
Actually, in your institution, what is the percentage of patients who go successfully for biopsy under ultrasound or CT?
So we do all biopsies ourselves. This is the only biopsy we don't do ourselves. And the distance at which the interventional radiologist is there from my center is 60 kilometers. So if it's only cost that I have to offset, then I offset the cost and do a laparoscopic biopsy, because I have to rely on interventional radiologist who's not present at my center. But the success rate is very, very good. They are very efficient and they can do all the biopsies, apart from the situation that it is really close to the aorta only and just around peri-aortic region. Then they are not comfortable puncturing it.